So harder pipes, or if they have gunk inside the pipe, then the narrower the pipe, higher the pressure. So let's go through some of these agents, how they work. Renin-angiotensin-aldosterone system. You guys know what that is? You can't? Okay, wonderful. So just super quick, renin produced by the kidneys when there's a stress of some kind. Can be a shock, can be some reason that causing the adrenaline to go, renin's being produced, causing the angiotensin enzyme to come out, converting angiotensin 1 to 2. Angiotensin 2 produces aldosterone downstream. Angiotensin, both 1 and 2, are vasoconstrictor. They cause the vessel to clamp down. So what happened is, especially angiotensin 2 is a very, very potent means strong vasoconstrictor. So if you have lots of angiotensin around, it will clamp down and blood pressure will go skyrocketed. So this group of medicine will work on either the angiotensin or aldosterone or the enzyme that involved in the system. So first one, angiotensin converting enzyme inhibitor, a mouthful. ACE inhibitor is what we call it. They generally ends with the word pril, P-R-I-L, but not all of them. There are medicine that ends with that, and it's not a ACE inhibitor, but generally they are ACE inhibitor. We have captopril, which is Capitan, which is much older agent, and it has to be given 3 times a day. Who wants to take a pill 3 times a day? So we don't use that as much. Enalapril works great given orally, injection via IV. That's called Vasotec is the brand name. Lisinopril, it's Prinavil or Zestril. That's also given, and it's only once a day. It's great. The newer agent, once a day, get the pill in, you're done. They are the ones that stop the converting enzyme from converting angiotensin from 1 to 2, so they stop the production of angiotensin 2 and go accomplish. However, it's not a complete block. What happened is sometimes angiotensin 2 is still being produced. Therefore, this group of medicine, they are pretty good, but not as strong of a blocking agent as the sartan, which are called the angiotensin 2 receptor blocker. They end with the word sartan, valsartan and irbesartan. Valsartan given twice a day, irbesartan can be given once a day. But what happened is the sartans block the angiotensin 2 receptor. I know you don't have to remember all the receptors, but once you know how they work, it makes sense. What happened is when they block it, then the angiotensin 2, that really strong vasoconstrictor, cannot go to the where the tissue is, where the receptors are, to produce that effect, to produce that clamping down effect. So the sartan works really well, and they work on the arterioles and veins alike. Some agents only work on the artery, some agents work on the vein. And you know how the artery vein affects the blood pressure? Have you heard about preload, afterload? Okay, wonderful. So this group of agent works on both, which is great. Now, as wonderful as it is, it works on both. It drops the blood pressure so significantly. Your patient might start complaining about dizziness, hypotension, and especially when they get up from a chair or from a bed. So guess what? When after surgery, they've been wiped out for a few hours, and if they continue to take this medicine the next day, they could potentially have fall, and fall risk is a big thing, as you know. So just something to consider if they're on a sartan or on a ACE inhibitor. They might have a higher rate of hypotension because they work so well on both arterioles and the vein. Again, the ACE inhibitor blocks the production of angiotensin II, and the ARBs, the angiotensin receptor blocker, blocks the actions of angiotensin II. People would complain about coughing a lot because there are angiotensin converting enzyme in the lungs. So they will complain of dry cough. Flu season is kind of hard on people. They cough anyways, but if they don't have the flu or cold and they keep coughing, and you notice one of these on their medication profile, something to consider. Hey doctor, my patient's been coughing and they are not sick with the flu or cold. What do you think? Okay. You had a question. Sorry, I couldn't pause for you.
Okay, so do the ACE inhibitors work on the arterioles and the veins, or just the ARBs?
So they both do,
They both do, okay.
because the ACE inhibitor blocks the production of angiotensin II. The ARBs works on the receptor itself, but they both, the angiotensin II is the common goal. Yeah, but the enzyme, they just block the converting part of that, versus the ARBs blocks the actual angiotensin II.
The site?
Yeah, so if it's easier just to draw it. So angiotensin 1 converts to angiotensin 2, correct? And ACE, it requires this enzyme to convert it. Yeah, so this is still the final goal. The ARBs works right there to block it from going to, it blocks the coming together of the receptor. But the angiotensin enzyme, when we block this, we only block the production of that. It doesn't block the actual action. So if they already bound to the receptor, there will still be some vasoconstriction happening. Good question. Side effects. It tends to retain water in some people. It's kind of strange, but angioedema is a real side effect, and your patient might have that, so be on the lookout for that if they become edematous. Hyperkalemia. All of this group will tend to retain potassium. So, and I imagine when you have your clinicals, you would keep an eye on the labs, and this is important because this entire group of agents tend to retain potassium. And too much potassium is not good. I mean, we need potassium for the heart to pump properly. But what does too much potassium do to the heart? Yeah, right. So what happens to the heart if we pump too much K into a person? Dysrhythmia, arrhythmia. You can stop the heart with too much potassium. So if and when you do give potassium supplement, especially intravenously, just keep an eye on their medication profile. Are they already on an ACE inhibitor? Are they already on a sartan? But if the doctors say, oh no, it's still important to give it, of course, follow that direction. They have a good reason. However, when you provide potassium supplement, just be careful. Not only it hurts the stomach lining if they take pills, which is not that big a deal, it doesn't kill them. But if you give intravenous potassium, please be careful. You can stop someone's heart. So if you give intravenous potassium, watch them. Like I mentioned, this entire group drops the blood pressure so effectively, it can cause a significant hypotension. The cough I mentioned, we do not give this group of medicine to patients who are pregnant because it's bad for the baby. Okay, and those who have cardiac situations, we got to be careful, and the renal impairment, because it works on that renin system, it can affect the kidneys as well. And then at the end of this pathway, aldosterone is at the bottom, and when we block the aldosterone, we'll get rid of that extra water, and that's how it works by getting lowering the blood pressure. You have a question?
Yeah, so what do you do for pregnant women with preeclampsia?
Yeah, so you would give beta blocker, something like labetalol for those who are severely hypertensive, or good old magnesium. Magnesium works really well. I know I'm not covering electrolytes in this lecture, but those are great questions. So calcium is for muscles, magnesium is for uterine muscles, potassium is for the heart when it's given the right amount at the right rate. Magnesium also good for heart muscle as well. Okay. Great question. Yes?
So if, for the diabetic population, which type of antihypertensive is preferred? Would it be the ACE inhibitors, or would it be like a atenolol?
Right, so they do mention that the ACE inhibitors are preferred, or ACE or ARBs are preferred for diabetics if they don't have kidney damage already, because it dilates both the artery and the vein of the kidney as well. Not just artery, vein of the body, but of the kidney as well. So it's super good. It opens up the preload and the afterload. However, once they have the kidney damage, it's not so good. It actually would harm it by lowering the renal flow. It is quite complicated.
So then they would switch them to a beta blocker.
Or calcium channel blocker. It relaxes things, and we will go through all those classes. That's why it's good to have time. Other questions? Okay. Shall we try to cover one more class, or you are ready for a break? One more class? Yeah?
Yeah, break.
Huh?
Yeah,
Break? Wait. I hear a break. So how about if we break from now till like 10:45, and we'll come right back. Okay? Wow.